Hello again, everybody. We're going to talk here about dysphagia, and we're going to be obviously focusing on causes of dysphagia that often have a surgical management. Now, I talk about a lot of these things in my GI section where I go over dysphagia, and that's all very important. So we're going to really hone in here on different kinds of dysphagia that can come up on surgery questions, whether that be on the USMLE or on your surgical shelf. So very, very important thing to get out of the way right now is that dysphagia means difficulty swallowing. Okay, difficulty swallowing. It does not mean painful swallowing. Can you have difficulty and pain? Yes, but painful swallowing is called odynophagia, and that has a completely different differential diagnosis than dysphagia. That's very, very important that you know that before we even start any of this. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. All right, so this is going to be what we're going to talk about. All right, so let's start with a vignette to see how these kind of come up on the USMLE. So we got a 59-year-old man who you regularly see who's coming into the clinic complaining of difficulty swallowing and quote-unquote vomiting for the last 2 months. He says that the food seems to get caught up in his throat. He points to his upper neck. He says sometimes after dinner he vomits, but that it tastes and looks like what I just ate. He is otherwise healthy, active, and has no other medical problems. Physical is unremarkable, but when you assess his dentition, you note halitosis. All right, what are we dealing with here? This is a Zenker diverticulum. So he's got dysphagia, he's got no pain, and then he's got this vomiting. So right away, when you hear of somebody who has difficulty swallowing and they're vomiting a lot, you might think, oh, that's reflux. And indeed, it can be. However, what gives this away is that he's not actually vomiting. He is regurgitating. Vomit should be acidic. It shouldn't really taste a whole lot like what you ate. Whereas if you're regurgitating, that is going to be very similar to what you just ate, especially if you regurgitate shortly after eating. Now, the other big hint here is halitosis. So what we're dealing with here is a Zenker diverticulum, and a Zenker diverticulum is an outpouching that kind of looks like that, and the food will come down and it'll go into this little pouch. Well, what's going to happen then? That food is going to get stuck there. It's going to rot, and it's going to start to stink, and that will come up through their breath, okay? So that is how you get halitosis and a Zenker diverticulum, and it's a fairly unique finding when it comes to the different causes of dysphagia. So Zenker diverticulum is a false esophageal diverticulum. That is important to know. So we just have outpouching of the mucosa and submucosa. And the classic presentation is dysphagia with regurgitation of undigested food. Now, this will tend to be in an older patient. These patients may have a history of pulmonary infections, so they may have an aspiration pneumonia from time to time. That may be given to you in the history. Symptoms, we already talked about. So dysphagia, regurgitation, that's the big one. Sensation of fullness in the neck because this can compress against other structures in the neck. Halitosis is a big one. And then another one that's really common but is not going to be given to you on your exam because it's a dead giveaway is that occasionally the patient is able to manipulate, squeeze their neck, and they can actually express that food that's stuck in the diverticulum. The best initial test is a barium esophagram. Why? Because this is a structural cause of dysphagia. So when you are suspecting a structural cause of dysphagia, like Zenker's diverticulum, then your best initial test is a barium esophagram. And that is because that allows us to see the contours of the esophagus because we're looking for a structural obstruction. Okay. Now the treatment is a cricopharyngeal myotomy. That is the gold standard. There are other other surgeries that can be done, but cricopharyngeal myotomy is what's going to be asked on your exam. This is the Zenker diverticulum here, or at least where it would be. So this is Killian's triangle. And Killian's triangle is made up of the inferior borders of the inferior constrictor muscles, one on both sides, and the superior border of the cricopharyngeus. This is a weak area. The esophagus can protrude out. And so this is where we get the Zenker diverticulum. It's posterior from the esophagus. This is the barium esophagram. Obviously, you can see why we go to this first. Barium esophagams are very easy. They're very cheap. And what you see here is the diverticulum. You can see it again here. The cricopharyngomyotomy is a fairly straightforward procedure. Obviously, anytime you're cutting, you run the risk of perforation. And because this is around the esophagus, you know that very important nerve that comes around the esophagus, the recurrent laryngeal nerve, you can get paresis or paralysis, which would result in vocal changes. All right, let's do another vignette. We got a 59-year-old man coming into the clinic complaining of difficulty swallowing food, which he says has been getting worse over the last several months. He says that the food seems to be getting caught up in his throat. He also says that he has heartburn from time to time, for which he takes Tums. His medical history includes type 2 diabetes, controlled on metformin. His BMI is 29.3, unchanged. And that was when he was last in for his A1C levels. Physical exam is unremarkable. So what are we dealing with here? This is an esophageal stricture. Why? Because this guy has dysphagia, and he also has heartburn that's controlled with Tums, or at least that's what he's taking. He likely has long-standing reflux disease, and that has caused this stricture. Reflux disease is the number one cause of esophageal strictures, and you should suspect reflux disease and stricture in an otherwise healthy patient with, no big risk factors or alarm symptoms who's got dysphagia that has been going on for some time. Okay, so again here we're talking about an obstructive cause of dysphagia. We're talking about a structural cause. We're not talking about a motility cause. So this is just simply narrowing of the lumen due to a stricture. The most common cause is reflux disease, but there are a number of other causes that could be a potential cause for esophageal stricture, but usually it's reflux disease. So know that reflux disease is the number one cause of stricture. The symptoms are pretty straightforward. Progressive dysphagia. Really look for that history of reflux disease, particularly reflux disease that has not been well controlled. If you've got a patient with a stricture and they have reflux disease and you have not been able to control it, that's a pretty darn good indication to go ahead and do a fundoplication for reflux. The best initial diagnostic step is, of course, a barium esophagram. You'll be able to see the stricture very evidently. EGD is also appropriate if that is given to you and not barium esophagram. That is fine as well. You will be able to see the stricture on EGD. But barium esophagram, I would go with first, just simply because you can rule out a stricture that way. You can see potential other problems, and all of that is good to know before you do an EGD. The treatment here, and another reason why EGD could be a good first test, but it definitely needs to be done at some point, is that the management is esophageal dilation. And that is going to be the best treatment for this disorder. So here is the stricture. You can see very obvious here. You have this narrowing. The esophagus should kind of go down like that, and then into the stomach, and you see this stricture here. And it's usually going to be in the distal esophagus because that is where reflux affects the esophagus. This is just your endoscope with a device on the end that you can use for dilation. All right, 59-year-old man coming in with difficulty swallowing food, which has been getting worse. He says that the food gets caught up in his throat. We've seen this before. The patient is a recovering alcoholic, and his medical history includes reflux disease, which has been an ongoing issue for the last 25 years, so long-standing GERD. You note that he's lost 15 pounds since his last visit a month ago for back pain, and he says that he has not been trying to lose weight. Physical exam reveals mild cervical and left supraclavicular lymphadenopathy. What is going on here? So remember those alarm symptoms? This man is a walking alarm symptom. So, okay, he's got dysphagia. The first thing we need to think of, just like when we're talking about GI bleeds, we need to think of potential alarm symptoms. Well, he's got uncontrolled GERD. It has not responded to any kind of management he's been trying. He's lost weight unintentionally. He's got bony pain, and he's got lymphadenopathy. So this guy has got tons of very concerning features that make us think that there is a malignancy going on. So esophageal cancer comes in two flavors. Adenocarcinoma, which is linked to reflux disease, tends to be in the distal esophagus, and squamous cell carcinoma, which is linked to smoking and alcohol, and is usually in the proximal 2/3 of the esophagus. There is some racial predilection. Non-whites are more likely to get squamous cell cancer than white people. White people are more likely to get adenocarcinoma than non-white people. The symptoms are progressive dysphagia and then your typical symptoms of cancer: weight loss, bone pain, lymphadenopathy. You could throw in night sweats in there, and then symptoms potentially relating to the underlying cause, which could be epigastric pain, reflux symptoms, upper GI bleeding, because the cancer itself can ulcerate. You may see a positive stool guaiac, you might not. Often it's not a whole lot of blood, but you can certainly bleed. And if this is a very, very significant bleed, then what we would expect to see is hematemesis. The diagnosis here, I would start with a barium esophagram and then do EGD and biopsy. And the reason is because you want to know kind of where this tumor is sitting before you go in with an endoscope. It just makes things easier. And like I've already said, barium esophagram is cheap. The treatment depends on the stage. So if this is very, very localized, remember you're going to get a CT abdomen, PET scan, and all that stuff before you plan your cancer treatment. If it's very localized, you can do a resection and you can be done. Otherwise, it's going to be resection with chemo and radiation. But in patients who have metastasis, then the treatment is simply palliative. You will not be asked about treatment for esophageal cancer. You just need to know the risk factors, how to diagnose it. So here's our EGD. We're going to get a biopsy here. And obviously, you're just going to go in, take a little biopsy, send it off to pathology, and then you'll know it's cancer and you'll begin your planning. 43-year-old woman comes into the clinic complaining of difficulty swallowing food and liquids. So food and liquids, very important. And that's been going on for the last 2 months. She denies significant pain, but says there's a feeling of fullness and pressure in her chest when she eats. She says her symptoms have been getting worse. She doesn't smoke or drink alcohol, has no chronic illnesses, and her weight has been stable. So now we're dealing with a patient who has difficulty swallowing food and liquids. And what that tells you is that you are dealing with a motility problem, not a structural problem. Now, this scheme is not perfect, but for your exam, it's perfect. Okay, so difficulty swallowing solids, which may progress to difficulty swallowing liquids, that is a structural problem, whereas difficulty swallowing food and liquids from the outset, that is a motility problem. Now, she's got this feeling of fullness and pressure. It's been getting worse, but there's no pain. Okay, no pain. So she's got a motility dysphagia, no pain. It's been getting worse, and she feels fullness and pressure. This is achalasia. Okay, so achalasia is a motor disorder characterized by a loss of proper peristalsis and a failure of the lower esophageal sphincter to relax. That is the characteristic of achalasia. Now, the symptoms will be to both solids and liquids. They may have weight loss, and the reason is pretty obvious. If it's difficult to eat, they're probably not going to eat as much. So you need to ask them, if they say they've lost weight, are you eating properly? Is this intentional? And then gather from there. In cancer, they're eating properly and they're still losing weight. Diagnosis here is going to be, you're going to start with a barium esophagram. Now, often we like to think if we're dealing with a patient who has a motility issue, we're going to start with manometry, and you can start with manometry, but a barium esophagram is going to give you an idea of what you're dealing with, because there's going to be a lot of difficulty getting that contrast into the stomach. So it'll pool in the distal esophagus, and that's very typical for achalasia. However, esophageal manometry must be done because that is the most sensitive test. So even if you don't see characteristic findings on barium swallow, you still need to get the esophageal manometry to exclude achalasia. The treatment is a Heller myotomy. Basically, what we're doing is we're just going in and weakening the lower esophageal sphincter. The problem is it's really hard to get the right balance. So what we'll do is we'll weaken it really well, and then we'll also go in and do a fundoplication, which kind of strengthens it. So you kind of balance the two. And it's always a struggle. You know, if you're getting a fundoplication for a patient who's got medically refractive reflux disease, you're likely going to give them an achalasia-like syndrome. Whereas if you were to just do the Heller myotomy, you're likely going to give them reflux disease. So we've got to kind of balance them, and it can be difficult. Now, if a patient is not a candidate for the Heller myotomy, we can do Botox injections into the lower esophageal sphincter. The problem with that is it's done endoscopically, but Botox does not last very long. We're talking 3 to 6 months maybe. So this is something that's going to have to be repeated. Now, manometry can occasionally come up on your test. Usually when it does, it's going to be for achalasia or DES. What we see with a normal manometry is you see this peristalsis, which occurs over time down the esophagus. So you have your contraction in the upper esophagus, then your contraction in the middle esophagus, then your contraction in the lower esophagus. And you should see a drop in your lower esophageal sphincter pressure, and it should go down pretty close to zero. Now, with achalasia, what you see is a high tone of the lower esophageal sphincter and a dip, but it doesn't go down very far. And so what you see here is inadequate relaxation of the lower esophageal sphincter. This is normal here, and this is abnormal. And so again here, you see a very high resting pressure of the LES and just not a whole lot of relaxation. You also don't see a lot of coordinated peristalsis either. But again, the characteristic is impaired relaxation. This is the bird's beak that you see on esophagram, just a little bit of liquid going down into the stomach. You can see here then why this is difficulty with liquids as well. Because none of this is food. This is all liquid pooling up here. And this is the Heller myotomy. All right, let's do one more vignette. We got a 43-year-old woman coming into the clinic complaining of intermittent chest pain over the last couple months. She says it usually comes on when drinking her morning coffee. She was recently seen for similar symptoms in the ER. She was given a cardiac workup, a lipid profile. Everything was normal. They even gave her a cardiac stress test. That was normal. She's in great health. Her weight is stable. All right, what are we dealing with here? So this is a little bit different. So this is more chest pain. And this chest pain is associated with drinking hot beverages. Okay, and the woman is otherwise healthy. So when you've got a patient with chest pain and you've ruled out all the malignant causes, you've gotten your chest x-ray, you've ruled out an aortic dissection, you got your cardiac enzymes, you've ruled out an MI, you've ruled out all the really bad things that it could be, then you need to start thinking about potential GI causes. And reflux disease is one of the big causes of quote-unquote chest pain, but DES is a slightly less common but still significant cause of intermittent chest pain. And one of the big things that they will tell you is that it is provoked by certain foods, typically hot foods and very cold foods. So a popsicle or a cup of coffee or something could trigger it. This is intermittent episodes of dysphagia and chest pain that's attributed to abnormal contractions with normal LES relaxation. So food will get into the stomach. Once these spasms are gone, the patient is generally fine, and that's not the case with achalasia. Symptoms are chest pain, dysphagia to both solids and liquids, and sometimes regurgitation. Diagnosis here is going to be manometry. Now, the reason you would not start with a barium esophagram here is that you would only see findings on the barium esophagram if they're having a spasm. So if you just do the esophagram while they're fine, you're not going to see anything. So what you need to do is have them on manometry, and then eventually you will see a spasm. But it can be a challenge because we're waiting for something. Now, the initial treatment is going to be calcium channel blockers, PO. So you can do calcium channel blockers, you can do nitrates, but typically we start with medical management. If that is not sufficient, then you can do myotomy. So here you can see the esophageal manometry for DES. The classic finding here is that you have this double peak. Okay, so normally it should look like this, 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 and this, and so forth. What you see here is this double peak, and they're kind of all happening at random times. Okay, so that is typical for DES. Another thing, though, that you see is that you do have a fairly normal LES tone. So the LES can relax, unlike with achalasia. This is the corkscrew appearance that you would see if you were to get a barium esophagram on a patient who is having an episode of DES. But again, best initial test when you suspect diffuse esophageal spasm is, in fact, a manometry. And then here is just a table of all the things we talked about, which are listed in red. The other things, again, you can go back to my GI talks because those are pretty much non-surgical causes of dysphagia.